Alrighty, and I would like to um, welcome our Memorial Health University team from Savannah. They are going to be presenting today on their site visit that was conducted in December of last year. So I will let them go ahead and take the stage, and I believe they're going to introduce themselves. But welcome, and Claire and I were so delighted to come down there in December, and I cannot wait to hear you share about it.
Oh. Laura, just about it. Can you see our slides?
You're good to go.
Okay, perfect. Well, thank you everyone for inviting us to present today. My name is Nicole Fallensby. I'm the director of the NICU.
I'm Suzanne Kirkaby. I'm the clinical nurse specialist at the NICU.
And I'm Dr. Torres, also joining here for the conference or the meeting. There.
Sorry, just give us 1 second for technical difficulties. Perfect. All right, well, we'll get started with this slide. So our unit here at Memorial Health is the only level 3 NICU in Southeast Georgia. We're designated as one of the 6 regional perinatal tertiary centers in Georgia, and we serve 24 counties in Southeast Georgia and parts of South Carolina. Our unit has recently expanded to 92 beds, and our average daily census for the past year has been 89. The unit is equipped to care for the most complex and high-risk neonatal cases, including extremely premature infants and those requiring advanced respiratory support or surgical interventions. The unit is staffed around the clock by a board-certified neonatologist, neonatal nurse practitioners, and specialized nursing staff. We also have a comprehensive support team, which includes respiratory therapists, occupational and physical therapy, speech language pathology, lactation, social work, and child life specialists. The NICU is open 24/7 for families to be with their infants. Our unit consists of private, semi-private, and pod bed spaces. We also have 2 overnight private rooms equipped with sleeping areas with bathrooms, allowing parents to stay close to their infants to gain confidence in caregiving prior to discharge. For our families that don't live locally, we also have a 12-bed Ronald McDonald House on campus that also supports our families. We have a dedicated March of Dimes representative that provides sibling support, parent education, and family support activities. We also offer our families access to the Angel Eye camera system, allowing them to view their infants 24/7. We encourage our families to be at the bedside for multidisciplinary rounds, but if they are not available, the providers utilize a function through Baby Steps to send real-time updates to parents daily, in addition to phone updates. This helps keeping them informed about their baby's progress. We also have a specialized neonatal emergency transport team that operates throughout the region, ensuring critically ill newborns receive timely care. This team consists of an RN and RT model, and they have the ability to provide nitric, cooling, high frequency while on transport. This team typically completes about 360 transports annually. Our NICU utilizes standardized feeding plans for our babies based on infants' weights. These plans include mother's own breast milk, donor breast milk, and Prolacta, depending on the infant's birth weight. We have 3 of these feeding plans. We have a centralized feeding prep room where all of our feedings are prepared. We utilize a standardized process for collecting mother's own milk and scanning milk into the electronic medical record. We are fortunate to have a very engaged lactation team. Last year, we recognized that we needed additional education for our bedside nurses in the NICU, and the lactation team held over 20 classes to complete education on breastfeeding, pumping, and how to best assist our NICU moms with providing breast milk. As we continue to hire each new nurse, we will have the same education to ensure consistency. We have lactation support also available 7 days a week from 7 A to 7 P in the unit. Breast pumps are available at each neonate's beds for moms that are breastfeeding to help encourage pumping. And we also have a March of Dimes family support person in our unit. So she has worked with our lactation team, and they have a class now, the infant nutrition class for our NICU families, and they hold that monthly. This class goes over benefits of mother's own milk and topics that are helpful for our mothers. We found that this class is very beneficial in helping support our moms, not only with education, but building a support team of other mothers for encouraging each other. Our NICU team was really excited to welcome the GaPQC team, which consisted of Laura Patillo, Claire Eden, and Dr. Brandy Giesling last December. We volunteered for the site visit because providing mother's breast milk is an initiative in our NICU, so we were excited to have the opportunity to have a team of experts come to our unit to provide feedback and ideas on how we can continue to improve. Prior to the visit, our staff was given the opportunity to participate in an anonymous online survey regarding best practice around human milk and breastfeeding for the very low birth weight per the AAP. The site visit included a meeting with leadership, a tour of the unit, we were under a lot of construction, we still are, and brief interviews with staff and patient families. We were later provided with a report consisting of both accolades and recommendations, including curated resources for our goals. We also opted into a policy review and training using breastfeeding intake scales for our pre and post feed weights. We found the visit and the feedback very beneficial to our multidisciplinary team and have implemented some of the changes, and we are seeing some positive outcomes. Our neonatal leadership team here at Memorial consists of myself as the director, 3 managers at the time of the visit, but we now have 5, a transport coordinator, clinical nurse specialist, and 2 educators. Our medical team consists of 9 neonatologists and 9 neonatal nurse practitioners. We are very fortunate to have a very engaged lactation team and are working on recruiting 2 additional IBCLCs. As we discussed in previous slides, we have a robust support service for this NICU. Our lactation team consists of both CLCs and IBCLCs. The CLCs on the team must obtain their IBCLC within the year of starting at Memorial. We currently have 5 IBCLCs and 1 CLC and are recruiting for 2 additional IBCLCs to support the mothers and babies. Our IBCLCs are available from 7A to 7P, and we have a very collaborative team that work closely to ensure our babies with feeding challenges especially are met from a multidisciplinary view, which includes lactation and our therapy team. Our NICU has 4 OTs, 2 PTs, and 3 speech therapists that work with our babies. They typically evaluate and manage infants beginning at 33 weeks for any feeding or swallowing concerns. Our NICU opened its first milk preparation room over 10 years ago. We recently renovated the room to follow the guidelines from the Academy of Nutrition and Dietetics. Our milk preparation area has 3 rooms consisting of an anti-office type area, a storage room, and a preparation room. A picture of the preparation room is shown on the slide. This is half of the room. It shows 2 workspaces for prep. We have 4 workstations for daily milk preparation for the NICU. The room is led by a milk prep RN and has 2 techs in the room working each day. We have a total of 6 techs and 5 RNs that are trained to work in the milk preparation room. All of our feeding techs have completed a comprehensive orientation and have obtained their certification in milk preparation. This room is open from 7A to 7P daily, and we have 2 prep cycles that take place each day. Once feeds are prepared, they are delivered to the fridge located in the NICU for the nursing teams. As you can see on this slide, our team surveyed felt that we as a leadership team have a high priority on ensuring proper milk handling and storage. Our team has been very passionate about ensuring we treat all feedings like a medication. It's very important to our team that each baby receive the correct feeding. Our facility utilizes a milk management system with a barcode scanning, which is done on all of our NICU feedings to ensure the correct patient is getting the correct feeding. This also ensures that the feedings have not expired. We have a standardized process for our moms who provide breast milk. They're able to print their own labels from a breast milk They're able to print their own labels for breast milk containers at a kiosk that is located at the main check-in desk. After the moms label their breast milk, they can drop it off at the main desk, and a tech validates that the label on the breast milk container matches the mom's baby band. This milk is then transported to the fridge or freezer. And as mom drops off her collected breast milk, we then provide her with additional supports for collecting milk. The prep team will pick up the milk and scan it into our milk management system. All products are scanned into the system as they are being prepared to ensure the correct order is being followed for the correct patient. Once it is prepared, the feeding is brought to the appropriate unit for the nursing team. Prior to the feeding, the nurses will scan the feeding and the patient barcode to validate the correct patient and feeding. This model has worked well for us in decreasing our feeding errors. Each NICU also has a designated milk collection cleaning area and sink. These locations are stocked with the supplies the mom needs to safely clean and sanitize her milk parts. We also ensure that our moms who are providing breast milk to their babies have a breast pump at their baby's bedside to assist with pumping every 3 hours. We think this model has helped with decreasing errors and increasing ease for our moms that want to provide breast milk.
This is Dr. Torres. I want to kind of mention about the initiative we did in regards to the early pumping. As much as Nicole has explained all the benefit and all the support that we have for our moms, one of the things that we know from research that it really makes a difference in regards to the production of milk is those early pumping, preferably between by 6 hours. So the early of this last year, we recognized that we have not have our percentage of early pumping as we will want it to be. So we kind of like have new discussion, interaction, collaboration between all the units, meaning, the NICU, which is the ones that we know this is what it's needed for, but most important, the mother baby and HRP and labor and delivery. So we started the education from first with all the NICU nurses, making sure that we are having our nurses aware of the importance of this. We got 100% compliance by then. And closer to the end of the year, then I started the initiative with the mother baby and the L&D nurses, making sure that that is where the impact is. Being aware of the documentation of this and be able to add this into scorecards and comparison, it makes a difference. Besides just saying, yes, we're doing or not, we are able to follow those numbers. Now we know that the mother baby had 100% compliance in regards to educating those nurses. HRP were up to 97% compliance, and the L&D nurses are 91%. That is the first step that we are moving in regards to knowing that now the nurses are educated in how to do it, why to do it, and really kind of talk to this mom about the early pumping. Us, our neonatologists, and our nurse practitioners, we continue to discuss the importance of breast milk to this month when we do prenatal care, prenatal consults, which we do with most of the moms that if we have enough time before they deliver, we talk to all the moms that are coming to the NICU. We explain the importance of breast milk, why we will like them to help with this, and as possible to pump as soon as they get settled. The ones that we have a little bit more difficulties are the mom on magnesium. They seems to be, obviously not feeling well, being a little weaker, being just nausea or whatever. So they seem to just need a little couple more hours, but we're still trying to enforce those 6 hours mark in order to get the benefit of it. One of the other discussions we have is having a transport in. Those moms were not necessarily talking with them before delivery and or right after from our staff and our nurses, but we do have our transport nurse talk to those moms. We are hoping we can actually provide like a small kit that have some of the early containers for early pumping, and just some that they will have at least hand on to bring to us when they're coming and visit. So a little cooler, so fake ice or just ice packs that they will be able to bring to us already with some of the early milk, and continue to tell the staff there to help us with this mom, since the moms will stay in those facilities and will bring the babies with us. Yes. So this is just this year that we have been able to kind of track these numbers and this percentage. We see where obviously our goal will be 100%. We're not there yet, but we definitely have seen an improvement recently once we know that this is where we want to be, and this is where we are tracking, documenting, sharing the importance, and giving feedback to those moms, not necessarily to the mom, but to the staff. If we're not able to pump them early, discuss why not, and document if the mom just not interested.
So the Uber Preview program began in 2021. This is a specialized team that cares for our neonates between 22 weeks and 24 and 6/7 weeks gestation. To date, we have successfully resuscitated 109 Uber Preemie neonates with a 67% survival rate in this population in 2024. The team has a set of guidelines that are followed. These guidelines change frequently as new research and best practices are discovered for these tiny neonates. The team begins with oral immune therapy early and educate parents on the importance of breast milk. As soon as the arterial line is removed, parents are encouraged to do skin to skin with the neonates. Pumps are at the bedside for mothers to be able to pump after skin to skin or any time when they are present. So, as you can see from our leadership staff survey responses, the leadership team supports Mother's Own Milk and lactation services. From the Nutrition Committee, which is a multidisciplinary committee that includes physician, nurses, lactation, just dietitian, to standardized feeding plans. They review best practice, revise policies, implement staff education, to the supplies that are required, like the milk management system for milk safety and documenting the feed in the EMR. The leadership team feels there's a good infrastructure to support in providing mother's milk and lactation services. Although these are some of the areas of opportunity, although these items may not be in policy format, many of these opportunities are in practice. Goals are discussed with mothers by the providers and the lactation team. There could be improvement for documentation in the EMR that the NICU team is able to find these conversations. The milk room does try to use fresh milk over frozen. And if there are concerns around a medication when lactation is not here, the milk is labeled and saved until there's an answer if it may be given to the neonate safely or needs to be discarded. So you can see from these survey results, the team is well aligned with recognizing the importance of facilitating mothers to express milk early and often, and when in the unit, the infant, with the infant, they're able to express at the bedside. So from these survey results here, you can see there is lactation consultants available 7 days a week from 7A to 7P. So from these survey results here, you can see hands-on pumping was part of our last year's education in the NICU. We are also looking at adding breastfeeding champion nurses to have additional education to help other nurses with lactation questions and processes. This will be voluntary, and we expect to have the nurses on all shifts. We will also ensure that we have education on the goal volume in our annual lactation education for the NICU. So here are some of our interview themes with our patient families. From these comments, you can see the dedication of our team to ensuring mother has the support to provide mother's own milk. You have the provider's commitment to talking to the mothers early on the importance. You have the nurses and women's services helping the mothers with pumping early. You have the NICU nurses teaching mothers oral immune therapy and the importance of skin to skin. Lactation consultants talking to mothers about milk supply and helping with breastfeeding when the neonate is ready. One of my favorite comments here is my baby was born at 24 weeks gestation, and a huge team helped us with skin to skin when he was still intubated and on the jet. So here are some of our interview themes from our staff. From the interviews, you can tell that the nurses' goals are to support the parent and use resources available if needed, lactation and providers if unable to answer questions. The one I love here is I try to use skin to skin to be associated with tube feedings to prepare the mom and the baby to be successful with breastfeeding.
It's me. This is Dr. Torres again. after the team came and did a 1 hour training for our staff, it was definitely evident that we needed to hear this. We needed for you guys to kind of just give us any information and what it is available. I think the pre and post weights, having something that our lactation consultant had mentioned, we as of now have been using time to assess feedings or full feedings or half of feedings, and there's plenty of evidence that that is not necessarily accurate. So it was the perfect time between lactation having talking to us about trying to change this approach, and the timing of having you guys come and talk about this initiative was like perfect timing. So we were really happy to have you guys here, hear what the project is, knowing and learning about the scales and the opportunity to use them. And so we had more conversations after that about reviewing our cue-based feedings policy, which currently it is time-based, and we are discussing about using it for the breastfeeding part to do pre and post weights. And being a change in policy or changing and changing guidelines, it does take a process, but we already have some plans in regards to use it pretty much for all babies and all breastfeeding attempts if the baby is more than 35 weeks, using the evidence data from articles that shows that at that point the babies are able to extract more and be more effective in regards to a feeding volume. Before that, in between the ages of 33 weeks to 34 and 6-7, we will be attempting breastfeeding. We will do pre and post weights with the guidance of lactation and then supplement half of that. The reason why we're still thinking of not using the pre and post weight for babies that are more in the premature side is there is a little bit of anxiety for those moms using the pre and post weights or using anything in regards to the lactation. And we don't want to put the pressure on them if the baby is not feeding well, because we anticipate that that is expected because of the prematurity. The same way as if for any reason those babies do get the bottle, they're also not completing those feedings. They get half of that, a quarter of that, they go back to sleep, and then we go bars the rest. So we're trying to continue to educate the moms to do the breastfeeding attempt, but don't worry about the intake. That will continue to improve. Currently, we are doing some pre and post weights and using the scale that we have available, but also doing just a routine or usual weight scales, and it has been successful. We have definitely seen a good approach from the nurses and from the parents, and obviously from the babies. And at this point, we're just trying to move forward with the new policy, and with that, then the reintroduction and the education from all the nurses about how to do this in order to make it just like a routine before, put the baby on the breast, after, and then supplement if needed or as needed.
So for our future plans, so one of the things that was a recommendation that we've already kind of implemented, we already had a nutrition committee, and we just made it more multidisciplinary. So we did add to the committee more nurses, lactation, dietitian was already a part of it, physicians were already a part of it, and we're looking at adding a family member also to make it a more multidisciplinary committee, and everything will kind of go through this nutrition committee. So just really trying to make it more robust. One of the things we already did after the meeting is we had an oral care policy. It has now been changed to an oral care and oral immune therapy for neonates policy. We're currently in the process right now of staff being educated for that. But the policy is out there. So we really aligned our wording and the processes with best practice out there. Just like Dr. Torres says, we're in the process of revising our cue-based feeding policy to get away from the wording of a good feeding or a time-based feeding, and really using that pre and post. weight that is best practice. Part of that, we have ordered 8 additional scales that we would need to help implement this process since we are such a big unit. So once we kind of get that policy and some of these scales in here, we will have to provide that education out to our entire team. We will continue with our quality improvement process that Dr. Torres has talked about. And then one of our big things that kind of came out of our nutrition committee meeting is that we really do have a young staff here, and many of them haven't even breastfed before their own children. So maybe really working to get some breastfeeding champions. It would be a voluntary, but give the NICU nurses that are interested some additional training and education and time to shadow with a lactation consultant. And then they're able to bring that information back to the bedside and be a resource to other nurses. And that's all we got. Any questions?
That is great. Thank you so much. Okay, we do have a couple questions. Give me just a moment. I'm gonna pause the recording.